Hi, health psychology students. My guest today is Dr. Chris Haymaker. And Dr. Haymaker, could you tell us what your job title is?
Sure. I am a behavioral medicine clinician educator. Often I just call myself a psychologist. It's
And
easier.
and where you work.
Oh, yeah. I work at, the full name is the Western Michigan Homer Stryker MD School of Medicine, but people just say WMed.
Thank you. And so your job is to teach, primarily your job is to teach medical residents,
Yeah.
medical resident physicians, correct?
Yeah. So there's a role within family medicine programs that's clearly defined for a behavioral science educator to be a faculty in the program and to help with interviewing skills and behavioral health and well-being. And here at WMed, I have that role with our family medicine residency program, and I also work with the internal medicine and the med peds program on sort of similar tasks, similar teaching.
So you teach resident physicians. So these are physicians they've gone through medical school,
Right.
and then they're in their residency and they're
Right.
doing their 3 years of residency.
Right.
And you're teaching them about how to interact with patients
Yes.
and also their own well-being
Yes.
and wellness
Yes.
and about psychological disorders as
Yes.
well.
Yes.
And so you're working with family medicine
Yep.
resident physicians, and internal medicine resident physicians.
Correct.
And what is an internal medicine? What is internal medicine?
So family medicine and internal medicine pediatrics and surgery and emergency medicine are all potential specializations that you can go into. And they all have postgraduate residency curriculum. So the family medicine postgraduate residency curriculum is 3 years, and then it allows you to sit for family medicine boards at the end of those 3 years. The internal medicine curriculum is somewhat different. Internal medicine and family medicine have some shared interest in hospital medicine and in outpatient medicine, but the training models are a little different. And so at the end of your 3 years in internal medicine, you would sit for your internal medicine boards. There are some combined programs. So Med Peds is a little bit longer, 4 years, and you can then sit for your internal medicine and your pediatrics boards at the end of 4 years. And then there are a few others, but that's all a part of the postgraduate medical education.
Thanks for clarifying that, because I was not aware of some of those specific differences before. So I thought it might be useful to talk about that.
Sure.
So you have a background in psychology. You are a clinical psychologist.
That's true.
Training,
Yes.
and you were in private practice for a number of years and saw clients and did psychotherapy, and then you took on the role of the behavioral science faculty, and now you're at this program doing something
Right.
similar.
Right.
So when did you find out that job existed?
So the job as a behavioral science faculty in the
that
family
was
medicine
a thing that people did.
I sort of knew of it in the mid 2000s when I was in private practice, because this local family medicine program had begun inviting me to do talks on pediatric topics, and family medicine physicians take care of people from conception to death is the idea. And so I would come and give a talk on pediatric topics like ADHD or depression in children or anxiety disorders, and got to know that family medicine program over the years, and then began to understand that there was somebody there that was doing that was doing behavioral medicine sort of programming there. And then, but I didn't really exactly understand the role until I was doing it. And sometimes I still don't feel like I fully understand the role.
Okay. So I wanted to just talk a little bit about that position because that's not it's not a type of position that most people know exists.
Right.
So I think that's an interesting piece of a biopsychosocial approach to health is educating physicians about those types of issues. What I'd like to focus on, if it is okay with you, is the patient-provider relationship and patient-provider communication. That's one of the things that we're talking about in the health psychology class right now.
Great.
So the first question and I know that you deal with a lot of things that address that. So the first question that I want to ask, and it's going to seem like, I think the answer seems pretty obvious to you, to me, probably to students in this class, but I want to ask it anyway. Why is that important? Why do you need to teach people about that?
Well, I think it just makes everything go better. That if you have, so for a patient, if they have an ongoing relationship with a provider, with a physician provider, then it's easier to talk about difficult stuff. And I think it's important to note, right, that the doctor that you go to, this is a very intimate relationship. And there's a lot of trust involved there. Certainly you're potentially gonna share some very important things in that relationship. And because we all value our health, and we all have concerns about health problems, you are gonna have to talk about some pretty difficult potential things with this physician. And so that's one of the reasons why it's really important for physicians to be skilled at developing a relationship where there is trust and where people feel safe to talk about what's up, because that's the way that they're going to get the best healthcare. If people are scared and nervous about the relationship they're in with their physician, then they're not going to share some things that they're worried about, and then that physician is not going to be able to provide the good care that they need.
And we've talked about pain and how pain is a subjective experience. So you have to get that information from the patient.
You have to get all the information from the patient. All of the critical symptoms, all the signs, you have to get from the patient. And so this, and it's really challenging to develop this relationship where you are moving through the day in these 15 to 20 minute meetings and to try to get a meeting going and to develop that relationship. So it really takes a lot of skill, to do that kind of thing. And, I think one of the other things that we maybe haven't talked about yet is that as providers develop relationships with their patients, right? They get to see them over and over again. It makes it much, much easier to provide good care because they don't have to re-ask all of the questions, and because they get to understand some of the things that some of their subjective experience a lot better. Because, as you say, pain is really difficult to assess. But if you know someone and you know sort of how they react to pain, and you've had multiple conversations with them about health, then you have a much better sense of what one patient's subjective pain ratings mean when they talk about them.
So that ongoing relationship is important for being able to understand people's subjective experiences. And we also know that when patients have a good relationship with their provider, they are more likely to be adherent to regimens, healthcare regimens, in part because they understand them better, probably, but they're also motivated to do so. And then They're also less likely to sue the healthcare provider if something goes wrong.
Yeah, and there are lots of really important things going on there, related to that. And so I try to help pick apart the things that people do to create relationship, and give physicians a sense of what they need to do in different phases of the interview. And I apologize. I need to take a brief break and come right back.
And we're back. So how do you go about teaching physicians how to do this? Do you observe them with patients? Do you do role plays? Could you explain some of the pedagogies that you use?
Yeah, I do a lot of direct observation, and I think it's important to keep in mind that resident physicians are not starting off with no experience, right? That they've already had, hopefully, multitudes of encounters with patients and sort of have some sense of this. But there's a lot of fine tuning that goes on. There's a lot of growth that happens in that 3 years of a residency program. So a big chunk of what I wind up doing is direct observation of clinical encounters, and then I give feedback about things that could go better. And I think one nice model that I work from is called the Calgary-Cambridge model. And there's the Calgary-Cambridge model. There's a nice sort of graphic representation of the things that have to happen during a physician encounter, right? So
do you have an infographic?
I do have an infographic, and I'd be happy to send it to you.
Okay. Sorry.
But there are a lot of things going on, right? So you have to build rapport and establish a relationship with a patient, and you have to build trust as you go along. At the same time, you have to ask really efficient questions to try to get to the root of what it is that the patient wants out of the encounter, and figure out what might be going on, so that you can come to some kind of a resolution at the end. And at the end of a traditional sort of outpatient encounter that might only be 15 minutes with your physician. So it's really a lot to do, and a lot of the feedback is around how you might be able to make that better. Some generic feedback that I often give people is about how to set an agenda with patients so that you know right from the beginning of the encounter what they want, so that you can fit that into what, as a physician, you think is important, so that you're addressing what the patient's needs are, what's most important to them. We talk a lot about open-ended questions, and which is not to say that you're never going to ask a closed-ended question as a physician, but if you start out with open-ended questions, then you collect more information, and then you can check off boxes in your symptom checklist in your head as you go along, and you can ask far fewer closed-ended questions. And asking all of the closed-ended questions takes a lot of time, and it's really frustrating for everyone, right? So those are some of the things that wind up happening. And then as you move through the encounter, the tasks change a little bit, because the physician will have a sense of what then needs to happen and has to do a little bit of teaching around, well, what is this? What's the plan? And then has to send the patient out the door with a game plan for how to achieve better health, or how to address a particular health issue, or whatever.
So the physician is also teaching the patient in these encounters as well.
Under ideal circumstances, and hopefully it's not a lecture. Hopefully it's participatory.
So I want to get back to agenda setting in a minute. But I wanted to ask too, so you do observations, you observe them with patients.
And right, and so sometimes role plays about particular sorts of issues. Certainly, there are lots and lots of didactics, and didactics is really just a formal kind of talk, right? Where I might give a talk on something that is a little bit more informational, right? So like encopresis, I might talk about encopresis. And there's some information that goes along with that. But then by the end, do I need to explain what encopresis
We need
is?
to talk about what encopresis is.
I'm sorry.
Just define it. Very brief.
It's fecal soiling. And usually I try to use poop in that talk as many times as I can, because I really want doctors to get used to using the word poop, because fecal is not the sort of word that a lot of people, enjoy, know, are familiar with. And so if you use fecal with a patient, it's just not. Plus, you're probably going to be working with a parent and a kid, and using fecal is going to make the kid feel a little weird. So you just might as well use poop. And in any case, and usually what's happening there is that it's the kiddo is constipated, and they're having they got a big ball of stool in their colon, their large intestine, and it's too big for them to pass easily. And so then what happens? They're still eating, and then the nasty liquidy stool that's not really digested comes out. So you have to have that kind of conversation, right? This is good stuff, right?
This was not exactly what I was planning.
No, but there's information that needs to be presented there. But there are also really important questions and processes and things that physicians need to be able to do around that, like use the word poop, that I'll talk about with them, and then sometimes have them practice. I don't recall having them practice much when I give my constipation talk, but for other talks, like giving bad news, it's really important for physicians to practice so that when they're giving bad news, they have the skills developed well enough so that they can be sensitive to a patient and a family who are in a very difficult situation.
Great.
Sorry about the poop talk.
Okay, so let's go back to agenda setting.
Yeah.
I'd like to talk about agenda setting. The students in the health psychology class are familiar with some aspects of motivational interviewing, such as the OARS acronym, so they know about open-ended questions.
Affirmations, reflections, and summary statements.
They know about those things, plus some other things. And but agenda setting is not something that we've really addressed yet. So could you talk a little bit about what agenda setting is? And I think you probably have an infographic that goes along with that. Maybe you'd be willing to share that with me.
I do have an infographic.
Okay. So just talk about what is agenda setting, and give us an example of what that would be like.
So the agenda setting that I teach is based on the work of another psychologist, Larry Mausch, who's done a lot of work on patient-physician relationships and specifically patient-centered care. And so I want to talk about patient-centered agenda setting, because that's really mostly what I'm interested in, as opposed to physician-centered agenda setting, which is where the physician just says, we're going to talk about this, and then bam, that's how it goes. So in patient-centered agenda setting, the idea is that it's a sort of a negotiation. And so certainly you want to start off with rapport, right? So you, as a physician, you really want to have a bit of small talk, like hey, how about that local sports team, or whatever. I'm not that great at small talk. But then you would quickly move into, if the patient hasn't already moved you into this conversation, what can I do for you today? What are you here to see me about? Sometimes you'll have a sense of that because there'll be a little chief complaint in the electronic health record, or the nurse or the MA who roomed the patient will say, hey doc, this patient wants to see you about such and such. And so then the physician will say something like, so I understand that you're here to talk to me a little bit about your left big toe. Is there something else that you want to make sure that we talk about today? And so this extra little question is going to do some really important work, because lots of patients have a hidden agenda or other things that they want to talk about. And sometimes they won't think to say anything about it until the very end, because they don't necessarily run meetings as a profession. And so it's the physician's job to run the meeting and make sure that there's a clear agenda at the beginning. So you say, left big toe, is there something else? And then what I teach people to do is I teach them to ask, is there something else, until the patient says no, right? And as they're saying, is there something else? Is there something else? To make a list of the things. So left big toe, chest pain, your dog died, the patients will come up with all manner of things, right? But at some point, and usually before you get to 10, usually just 2 or 3, they'll say, no, I don't really have anything else. Or sometimes they'll just say right at the beginning, I don't have anything else. What we're trying to prevent is an, oh, by the way, at the end, but we're also trying to make sure that we can get all of those complaints out at the beginning. Some of them might be related, and often you can really tailor your conversation to what's important to the patient and identify any can't miss symptoms during this conversation. So at the end of that time, you've got your little list and you say, so we've got this and this and this and this and this to talk about today. I don't know if we'll have time for all of those, but let's get started on what's most important to you. What is the most important thing for you to talk about today? And then that's probably one of the best ways to get patients on board with your medical recommendations, is to do the work that they want to do. And then to also be willing to say, hey, you know what? I know that it's really, I know that you feel very strongly that we need to talk about your left big toe. And if it's okay with you, I think it's very important to talk about your chest pain first. I'm very concerned about that. And that's a way of bringing patients along with you so that they're sharing in that decision making, and that you contribute, you're seen as a contributor of your expertise as a physician rather than bossing them around. Humans just don't like to be bossed around.
So asking permission, which is part of the motivational interviewing.
It is part of it, yeah.
Approach to.
It's a really good thing to do. And it's really just this wonderful, if I could say, this wonderful little, it's not really a trick. I think about it as a Jedi mind trick, but it's a really wonderful persuasion technique. It gets people to take just a small, gentle step towards entertaining an idea. And often the idea that we're wanting people to entertain in a health encounter like this is going to involve some kind of behavior change.
So that brings us to another issue of behavior change, and not just for family medicine physicians, but even specialists might need to address this with their patients too. Even people who are not physicians, I mean, professionals of a lot of different types might be interested in
even psychologists, even professors, even PE teachers, even, right? So, sure.
So what are some of the things that you see in medical residents when they come in that maybe they need more skill development with for encouraging behavior change or addressing behavior change? Maybe talk about the things that you like to really highlight, or the things that you see as the biggest need for them when learning these skills?
Yeah, that's sort of a tough question. I think that that in postgraduate medical education, physicians enter postgraduate medical education at lots of different places. There are just diverse training programs, and so it's a little hard to spell out where things are. I think for everybody, I really emphasize developing a relationship with patients, a non-judgmental relationship with patients. That's one of the first things. One of the stumbling blocks, right, is that after you've done your medical education and you have your MD or your DO, and there are a few other qualifications that can wind you up in school, in postgraduate medical education, but you've done so much studying and you know so much stuff that you're going to want to talk about it. And you're going to want to talk about it in the new language that you just learned, which is medicine. And that's tough, right? Because lots of times that's too many words for people, and it's not the right words.
It's like fecal and poop.
Right, like fecal and poop. I'm glad you brought that up again.
I wanted to bring us back to that.
There are just lots and lots of different examples of that, and so a lot of the development initially is around just being comfortable enough to talk regular and listen more, and that's a little bit hard too, because I think in medical education, one of the things that one of the skills that you learn, right, are the review of systems questions and the history of presenting problem questions, the history questions that are going to help you to figure out what is going on. And they're very checklisty. Do you have this? Do you have that? Do you have this? Do you have that? Do you have this? Which is great. And so you'll see at some points, right, when you learn about a new disorder, medical students will go through the checklist, right, with the patient. And that's in a lot of ways what you want. That's how you learn, is to go through the checklist. At some point along the way, you want to have committed the important signs and symptoms to your memory so that you can ask a question, an open-ended question, and you don't have to go through the checklist. That the checklist is in your head and you can check things off. And that then makes it much easier to have a relationship with people, because it's just really hard when you've got a checklist and you're going down the checklist to make eye contact, first of all, but then also for it to feel any kind of normal. But to have a conversation where somebody will say, well, so tell me a little bit about how long have you been having this chest pain and what's it been like? Then there's a narrative description that comes along with it that's a lot more like a conversation. And as that's happening, a physician can process, right? And so then the other, and that's one way to pare down some of that medical speak and the checklistiness, right? Another really useful way to pare things down is to use some strategies for assessing patients' understanding before you do the dive into what you need to know, because lots of physicians have like a 700 slide deck on whatever disorder you want and could talk about it for that long, but we really don't have that kind of time. So I like ask, tell, ask.
Ask, tell, ask.
Ask, tell, ask.
I don't know what that is. What is that?
So Cynthia, what do you know about the effects of smoking on your lungs?
I know it's bad, and I know it can cause cancer.
Yeah, would it be okay if I talk a little bit about some other things that can happen with your lungs when you smoke?
Okay, yeah.
So when the smoke gets in there, And then, so after I do a sentence or two, then, so you saw the ask, and then you saw me ask permission to tell. And then at the end of that, what do you think about that information about the elasticity of your bronchial tubes and how they're less elastic?
I hadn't heard that before.
Yeah, I just made that up.
Yeah,
but,
I knew that though.
But you then reassess at the end, and that ask, tell, ask sort of format can help you to really pare things down. And often what we're wanting is for physicians to be able to edit things for the person in front of them. And that means really condensing a lot of that information into some well-chosen sentences. And physicians get so good at it by the time that they're done with their residency. It's amazing to see the growth. It's amazing. It's amazing.
Sounds very rewarding.
It can be. It can be. I hope I answered that question.
You did. Yeah. Because I think that's a big piece of it, is the educational piece of it, and it's not going anywhere if you're not speaking in the vernacular.
Yeah.
If you're not speaking the terms that they understand, it's not going to do anything for you. And then also making them a partner in it. So then you can apply different kinds of things, like establish what their readiness to change is, or have them look at the decisional balance, the pros and cons, and the norms and the social setting that they're in, and all those.
And it's a lot to integrate all of that behavior change stuff into the practice of being a physician. But I see physicians pretty routinely getting to a point where they'll ask those readiness questions, partly as a way to enhance motivation, but also for efficiency's sake, that you don't want to provide all of that information to, all of the information about quitting smoking, to every patient who's smoking, because some of those patients are not interested in quitting, and some of them are only really thinking about quitting, and some of them are actively quitting, and some of them just had a failed quit attempt. And you really have to learn to interact with those different situations differently, so that you don't have to reinvent it every time, and so that you can, again, get your shtick down to a few well-chosen sentences, so that you can bring people along to the next stage of change and really enhance motivation. Or you can maintain your relationship with that person when they are not at all interested in changing behavior, so that you get another crack at them in 2 to 6 months. Because a lot of behavior change really happens over the course of months and years. And, one of the things that the doctors I work with and I talk about a lot is that you don't have to do it all in one encounter. You can't.
That makes a lot of sense. I'm just processing all of that.
Yeah.
There was a question that I had, and then I forgot what it was.
I do get a little wordy sometimes.
Yeah. Oh, here's what my question was. Now I remember it. So this is obviously useful for physicians specifically, and a lot of the patient-provider relationship and communication research has been done with physicians specifically, physicians and patients. And it's pretty easy to see how this would apply to lots of other healthcare kinds of situations. Do you think that these skills, knowing about these skills, is useful in other settings not related to healthcare?
Well, potentially. I mean, sure. So, agenda setting, right, and negotiating an agenda for a meeting is really handy anywhere that you might meet with someone and want to get something done, right? And certainly motivational interviewing is handy just about any time you're entertaining the possibility of behavior change. And I'm not sure if there's an arena in which we're not entertaining the possibility of behavior change. It applies to lots of different things. I will say that I haven't found it to be that useful in parenting, but that's probably complicated by my relationship with the child. So, go figure.
What would it be like if you actually picked up your laundry?
Yeah. I mean, that just doesn't go over that well.
I get that. Yeah. Well, Dr. Haymaker, thank you so much for joining me today, for being here. I appreciate
Well,
it.
thanks for having me. Thanks for covering travel expenses. I mean,
my pleasure. And thank you for joining us today as we talked about the patient-provider relationship and patient-provider communication. And really interesting information. Thanks again.
thanks. I'll see you later.
Bye-bye.